Good evening. It's really a privilege and an honor to have Dr. Abhay Bang talk to us today. Dr. Bang and his wife, Rani Bang, are both social activists and researchers working in the area of community health. They are the founders of the organization called SEARCH, which stands for Society for Education, Action, and Research in Community Health. It was an organization founded in 1985 in Gadchiroli in Maharashtra, which is one of the poorest areas of the world. And their work in this community has reduced infant mortality very significantly. It's always very nice when you get an award from your alma mater, and Dr. Bang and both Doctors Bang have received the Johns Hopkins Distinguished Alumni Award. They both did their masters in public health from there. I recently looked at the 150th anniversary edition of 150th birthday of Mahatma Gandhi's edition, which was brought out by IJMR, Indian Journal of Medical Research, which Dr. Bang, you were one of the editors of that. And I read your article in that. And there are two incidents that stand out, and both related to Gandhiji. The first one, he talks about when his father, who was associated in the Sarvodaya movement, went to ask Gandhiji for advice on going to US to study economics, to do a PhD in economics. And Gandhiji told him, if you want to study economics, go to the villages of India. So he gave up his plans to go to US and spent his life in villages around Wardha. And that's where Dr. Bang was born. And the other incident I recall is he, following Gandhiji's advice on resource conservation, decided not to use a fan, and for 5 years during his MBBS degree in Nagpur, he did not use the fan in his room. That requires extreme commitment, which characterizes his life and his work. Dr. Bang, please.
Yes, please. And how do you move this? Okay, great. Thank you. Thank you, Dr. Ibrahim. And thanks to India Alliance for inviting me to be here with you. For me, it's relatively infrequent that I speak to audience like you. Most of you belong to the biomedical research stream, and I don't get this opportunity frequently to talk to scientists like you. So for me also, it's a different kind of honor to be invited to talk to you here. What I intend to do today is tell you a story. Now, invariably, the story will be a little autobiographical, but I assure you that it's not a narcissist story about my successes. It's not. I'll also share with you journey of a research study from Gadchuli to global. And then, based on these stories and learnings, I'll try to draw some lessons and propose an alternative approach of research. Nearly 35 years ago, I start the story where Shah Ibrahim left. Rani and I went to Gadchiroli. I think at that time we must be of the age that you are right now, mid-30s, having had our clinical degrees in gynecology and internal medicine, and then having studied public health research at the Johns Hopkins. We had just come back to India and we were discussing where to settle. And those words of Mahatma Gandhi, which he had spoken to my father nearly 40 years earlier, were still echoing in our ears: go to the villages of India. And that's why we decided to go to this place called Gadchiroli. Now, the red area that you see there, Gadchiroli, at the eastern end of Maharashtra, about 1,000 kilometers from Mumbai, state capital, almost in the center of India, the remotest place for Maharashtra and one of the poorest places in the world, as Dr. Ibrahim said. It's red in two senses, but we'll come to that later on. Gadchiroli is densely covered with forest. Very few forests left in India, and Gadchiroli is one of them. Madia Gond is the predominant tribe there. Nearly 4 lakh Madia Gond tribes, and they at that time they still continued to live in their primitive way of life. There were 1,500 villages in Gadchiroli district, 0.9 million population at that time, 1.2 million now, distributed in 1,500 villages with huge distances and very low population density. Life was very primitive. The major occupation in the villages was paddy cultivation. So from July to September, people were occupied using bullocks, paddy cultivation. Rest of the months, they earn their livelihood by collecting various forest produce. So society is somewhere between primitive agriculture and hunter-gatherer society. The means of transport were very rudimentary. Bullock cart was the main transport medium. Even sick women, obstructed labor, sick children would be transported by way of bullock cart, and intermittently you heard noises of huge blasts, bomb blasts. The Maoist movement was very active, and even today it is very active in that district. One of the worst affected by the extremist violence. Dhanora block, where we live and work, is one of the worst affected in India. Just maybe a month ago, 15 police were killed in a bomb blast in Gadchiroli. So that's made the Gadchiroli. When we went to Gadchiroli, go to the villages of India, that was the lesson. And so when we went to Gadchiroli, a local trader, Gadchiroli was a large village of 10,000 population, still a Gram Panchayat. And a local trader very kindly gave us this godown for our work. He heard that this couple has come back from the US, so to make his contribution. So this godown became our office, our research center, our training center, our computer center, and for the initial few days actually we lived also in that godown. And for 7 years, all our earlier studies were conducted from this godown, which I am going to share few of these. Today, we live in a campus right inside the forest of Gadchiroli. We call this place Shodhagram, a place, a village, a search village, a village from where we try to search the methods and approaches for improving the health and health care of rural India. So I grew up in Mahatma Gandhi's ashram, which was called Sevagram, and I landed up in Shodhagram. So the journey essentially was from Seva to Shodh, from service to research. The Shodhagram is a campus where nearly 150 of us live together, a small hospital, a research center, training center, and staff quarters. And from here we work in the entire district, a district which has become for us laboratory. I have studied in several universities, sometimes even taught in several universities, but I think my maximum learning has occurred in this University of Gadchiroli. The medicine that I studied in medical colleges, the public health that I studied at the Johns Hopkins, everything was virtual. In the sense, the public health training all over the world, I guess, is never very practical oriented. It's more classroom oriented. So it is in the laboratory of Gadchiroli or University of Gadchiroli that I really studied, and now I'll begin with our first study of sickle cell disease. Within a few months of going to Gadchiroli, this girl was brought to me. As I said earlier, I am a physician also. So this 8-year-old girl with severe anemia, abdomen distended as you can see, and murmur in the heart. She was referred to me as a possible case of sickle cell disease and valvular disease, but there was mild icterus, which made me suspicious, and I thought maybe she has sickle cell disease. Now, no case had earlier been ever reported, not even tested in Gadchiroli for sickle cell disease, so it took me little time to establish, and she had sickle cell disease. Now, go back to my position, a young researcher, early 30s, and you are always, having been trained in the US, you are always thinking of being the first. So, oh my God, I had discovered sickle cell disease in Gadchiroli, which nobody earlier knew. So, big finding. So, in that enthusiasm, we organized a district sample survey. In randomly selected villages in each of the taluka of Gadchiroli, population-based testing for sickle was done. We could convince people to give blood sample, and we found that nearly 15% population had sickle cell trait and 0.8% population had sickle cell gene, which meant nearly 6,000 sickle homozygous and 100,000 sickle cell trait. The researcher in me was very delighted, and we invited the minister, a tribal minister, health minister, released the findings. They applauded us greatly. This was published in journal. Maharashtra government gave me an award called Adivasi Sevak Puraskar for this work. And the minister had also announced that because Search had done such research, he would soon start a research center for tribal health in Gadchiroli. We waited and waited, it never happened, and finally the research center on tribal health was opened in Pune, where there are no tribals. But the researchers wanted to live in Pune. So center went where the researchers wanted to live, not where tribals were living. So in the protest, we went to tribal leaders and tried to communicate to them that, look, this has happened, this is injustice on you. So you should raise your voice that the research center comes to Gadchiroli instead of being Pune. So they looked at us very blankly. And tribal leaders asked me, Doctor, did we ever tell you that sickle cell is our problem? It's your problem. You solve it. You came to us, we thought a young doctor couple has come, why disappoint them? So we gave you a drop of blood. We have nothing to do with problem that you are calling sickle. We have never seen it. We have nothing to do, we have no trouble with it. So it's not our problem, it is your problem. as if somebody had hit me with a huge stone in my head. What had I done? I had alienated the very people whose problem it was from that problem. Because of my intellectual itch and urge to find something new and publish, probably I had turned a non-priority issue into my priority issue, research issue. So I got publication, I got award, I got recognition, but nothing happened to the people. And they completely disowned the problem. The research publication is still lying somewhere in the shelf. After 35 years, nothing has happened to that research. And so we made for ourselves a decision. A decision is that research should address the needs of the community I work with and not the research community I report to. Look, all of us, either researchers or would-be researchers, mentally we might be working in any place, but actually physically we might be working in any place, but mentally we are always addressing to the research peers. We are addressing in our mind this kind of conferences, this kind of workshops. I will be speaking from the podium and there will be slides shown and the audience would be watching and maybe at the end applauding. This is the dream for every researcher. So mentally, we are really addressing very different global community, a research community, but in that urge, what do we do to the people on whom we do research? And in the end, with that research approach, what came out, as I said, was a publication which is still lying on the shelf. Nobody even looked at it. I am told, my son told me that there is some research which shows that average research paper published in the journals is read by 7 individuals, and one of them is your mother. This is the average readership of a research paper. And so we decided for us in search an ethical guideline that hereafter we'll never do a piece of research because it is our intellectual itch. We must do research which should address the needs of the people in Gadchiroli. So what were their needs? What did people want? We did not know. We had always looked for research problems in journals and gaps by scientific literature. Ronald Ross, whose guru was Patrick Manson, the founder director of London School of Tropical Medicine. And when Ronald was working in Sikandarabad on this topic of malaria and still struggling, what is the likely role of mosquito in malaria, he had gone on summer vacation to London and he was taking stroll with his guru on the footpath of London and he asked this question to Patrick Manson, and Patrick Manson said, "My son, if you want to do research on mosquitoes, learn to think like a mosquito." So how do tribal thought? What did people want? So we started going to villages. People were available. They had time only in the evening or during the night time. So we used to go in the night, sit around night fire with the people, and then people started talking about what their priority health problems were. So to further assess this, we called something which we call People's Health Assembly. And the representatives from 50 villages were called. 2 days discussions were held as to what they thought were their health priority. About 20 health priorities were identified and then we asked them to vote to identify the research priorities for search. Ordinary, semi-literate or illiterate women, tribal men and women, they voted. Everybody knows voting nowadays. And everybody was given 3 votes. They voted, and at the end of that, from that People's Assembly's voting, 4 problems were identified as the priority problem for rural Gadchiroli. Malaria, white vaginal discharge amongst women, alcoholism amongst men, and child deaths. Now these 4 priorities, listening to people, led us to the appropriate health priorities and series of topics for research. And these provided us a lifetime agenda for public health research. We are still working on those 4 problems, never ending. And I don't think we have solved all those problems, though we have made some progress on few of the problems. Now I am going to share with you only one story of those 4, out of those 4 research problems that people gave us. That's about child death. Now people said our children die. Can you do something about it? So being a public health person, we established a population-based laboratory in 134 villages, a demographic surveillance laboratory, and we measured birth, death, child deaths, determined the causes of child death. I won't go in the details of methodology. At the end of the first year, in 102 villages where we measured vital statistics, infant mortality rate was 121. This is year 1988. And the major causes of child mortality were pneumonia, number 1, and newborn mortality was number 2. Now, antibiotics for pneumonia were discovered maybe 40, 50 years earlier, but they had still not reached where they were needed. In the villages of Gadchiroli, in villages of India, how could antibiotic reach? Even more difficult was who would diagnose? There were no doctors, not likely to go to the villages of Gadchiroli or of in the rural India, and a child, an infant who has pneumonia is very miserable. And the child, if it doesn't receive therapy in 2-3 days, child could go either way. So how do you diagnose and give antibiotic to the appropriate child? It shouldn't be overdiagnosis, otherwise antibiotic resistance we all know. Counting respiratory rate is a very, very good way. Frank Shan was an Australian pediatrician. As a part of his internship, he went to Papua New Guinea and did a wonderful piece of research. I think I would suggest that everybody of you read it. It was published in WHO Bulletin 1985-86. In his OPD, he examined all the children with cough clinically and then also took X-ray and then compared, and based on that he found that counting respiratory rate in child with cough is a very good way, fairly sensitive, very good sensitivity and fair specificity to diagnose childhood pneumonia. So we decided to use Frank Shan's method of counting respiratory rate, but women in villages could not count. We were working with traditional birth attendant at that time. She is Yashodabai, a TBA, traditional birth attendant from a village called Bodli. So for enabling traditional birth attendant make diagnosis of pneumonia and treat child, because only they were available in villages, we had nobody else. So how could you train an illiterate woman to diagnose childhood pneumonia by counting the respiratory rate? So I had developed this breath counter. You can see there is a sand timer, 60-second sand timer, and there is an abacus. There are 2 rows, one for the newborn baby or young infant, one for the infant. There are, in the lower row for example, you would see there are 5 beats. Frank Shan had identified and later on WHO also recommended that if in an infant respiratory rate was more than 50, in a child with cough, if respiratory rate was more than 50, it is most likely pneumonia. This old woman can count up to 12. Why 12? Because of the British era of dozen. Everything was sold in the market by dozen. So she knows about how to count up to 12. That's necessary for survival. So this abacus doesn't require her to count more than 10. She turns the equipment, starts counting respiratory rate. For every 10 counted breaths, she moves 1 bead. If it is a neonate, she would select the upper row. If it is an infant, she would select a lower row. Before the sand is passed, that is 1 minute, before the sand is passed, if the red bead is moved, it is pneumonia. She doesn't have to know whether it is 54 or 44, she can't count. But if the red bead is moved before the sand has completely passed, it is pneumonia. I compared this, we trained 10 TBAs using this and 50 children with cough. I used stethoscope and my diagnosis of childhood pneumonia or non-pneumonia, and TBA's diagnosis using this breath counter. Their diagnosis was 82% cases, it matched my diagnosis. Good enough. For villages, now we had a method that even though there were no doctors, no stethoscope, but still ordinary women could be taught, and with that we started diagnosing and treating pneumonia with oral antibiotic. Now here you see about how many? 15 years result. This is little subsequent, but even the initial years results were very same. So before treatment was introduced, the case fatality among children with cough and high respiratory rate, presumably pneumonia, case fatality rate was 13.5%. With TBAs and community health workers diagnosing childhood pneumonia and treating with oral cotrimoxazole, it dropped to 0.8%. And the pneumonia mortality rate in the whole area of 158 intervention villages, we conducted a control trial subsequently, 58 intervention villages and 48 control villages, 2-year trial, intervention trial, and that showed that the pneumonia mortality in the population was reduced by 76% and the infant mortality from 120, it came down to 76. This study was published in the Lancet and it became the first controlled field trial which showed significant reduction in pneumonia mortality. Other studies were conducted by WHO at 6 different places, and a joint evaluation by WHO and Johns Hopkins University rated this Gadchuli study as the best one. And in 1993, when global ARI control program was designed in a conference called ICARI, the Gadchuli study and 6 other studies by WHO became the cornerstone. Based on that, the global ARI management strategy was decided. We were encouraged, but the next problem was newborn mortality, even more difficult. Infant mortality rate had come down to 76, but for the next 5 years we couldn't make much headway, because the majority of the now remaining infant mortality was concentrated in newborn period. Now newborn in villages are the most vulnerable human beings you can ever imagine. The first 28 days of life, first 1 month, is the period of highest risk. And how was newborn care in villages? This is a picture from village called Murza. A baby had been born about 8 days ago. As you enter in that home delivery room, usually the worst room in the house is selected as a delivery room, because that woman would be occupying it for 30-40 days. So family cannot afford the best room to be occupied. And you can see that woman, mother, still lying on a charpai, exhausted, pale. An old woman who could be grandmother, who could be dai, is providing newborn care to that baby. Baby is naked, baby is low birth weight, could become hypothermic. But look at the cow dung plastered floor, teeming with billions of bacteria, and hardly 3 inches away from the bare scalp or bare hand of that baby. No wonder that newborns became hypothermic, hypoglycemic, developed neonatal sepsis and died. Globally, nearly 5 million newborns died. And what was the standard recommendation? We looked at WHO UNICEF recommendation. Standard recommendation, sick newborn is a very serious condition, don't touch it. Immediately refer to hospital. But where were the hospitals? Gadchuli was 350 kilometers long district, but there was only one place, the district hospital, where there was some semblance of newborn care. Even today, you occasionally read stories about this hospital, Gorakhpur Hospital or Chandrapur Hospital, where large number of neonates died, because even today the hospital-based newborn care is really poor in India. So newborn care was inaccessible, and the tradition did not allow that mother, the postpartum woman, traditionally is supposed to be very vulnerable to black magic, to evil eye, to witchcraft. So she should not come out of that delivery room. Nobody should see her. So even if newborn was sick or if mother was sick, they were not allowed to leave that room. And even if they left, how could they travel 50, 100 kilometers with that sick baby and reach? And so hospital-based care, great, but great only as an idea. It wasn't a reality for majority of the villages in India. And at that time, globally, 5 million neonatal died annually. 1.5 million neonates died in India alone annually. So 26 million births occurring every year in India, out of whom 1.5 million neonates died. How to provide care to these neonates born at home? At that time, most of the deliveries were home delivery. How to provide care to them? Obviously, doctors was not the solution. And if these babies cannot reach where the medical care was, that is in the hospital, the medical care must go where the babies were. And so we decided to switch. China, when it planned its health policy in 1951, in its first National Health People's Health Congress, as it was called, they coined this very simple principle. They said, how far a mother on foot can walk with a sick baby in her arms? Healthcare must be available within that distance. No population worker ratio, no kilometers, nothing. A very simple yardstick. How far a mother on foot can walk. We thought this is a great guideline. And so newborn care, the mother and baby cannot even step out of that room. So newborn care must go where the babies are, and that's how we designed this home-based newborn care. Completely turned the neonatology upside down, and instead of hospital science should go where the babies were, and home-based newborn care with the goal of reducing neonatal mortality by developing low-cost home-based model of primary newborn care using the human potential in villages. And after so many years, I would like to make only one correction. Instead of saying human potential, I would now say using woman potential in the village. We designed a field trial, intervention area, control area, baseline data collection for 2 years, and then subsequently intervention for 3 years, 95 to 98. Baseline IMR was 76 and newborn mortality rate was 60. Those who may not know, NMR, newborn mortality rate, is how many, out of the 1,000 live births, how many babies die within first 28 days. Usually NMR in developed countries is 3 or 4. In Gadchuli, it was 60 at that time. After 2 years baseline data collection, in the intervention area, we selected, she is Kajubai. Kajubai is a woman, Dalit woman from a village called Ambe Shivne. This is her photograph taken nearly 30 years ago. 7th standard fail, because most of the women's education limit at that time was 7th standard fail, if at all they went to schools. A Dalit woman, but had a strong drive, passion to do something, to serve. 39 such women were selected from 39 intervention villages, one from each village. I will not go into the methods of selection of worker, etc., but the appropriate worker who could deliver mother and newborn care right in the home, in their own villages. They were trained through a systemic program of how to make visit to newborn, how to examine newborn, how to record various clinical parameters. And then after 1 year of data collection about newborn morbidity and causes of neonatal death, an intervention package was designed which was delivered So here community health worker Maya Bai is giving health education to, actually she is playing role play, she is giving health education lesson to another community health worker. This is during practice session, but how to give health education to pregnant women. And then attend the home delivery when it occurred. If the baby doesn't breathe at birth, at 30 seconds start newborn resuscitation intervention. Here these workers are learning and practicing how to resuscitate a newborn baby asphyxiated using the bag and mask. Put immediately to breast, early exclusive breastfeeding. Babies who were premature, low birth weight, were at the high risk of death. They become hypothermic. How to keep them warm? There were no incubators. So this kind of warm bags were designed for neonates. At the end of the training, we were little hesitant. We knew that we were completely flouting the WHO guidelines and standard practices in neonatology. So we invited 10 senior most pediatricians of India. I don't know if there are anybody here from the AIMS, Delhi. Is there anybody? Okay, good. NK. So you would recognize Dr. Meherwan Singh, of course. Dr. Meherwan Singh was the chairman of pediatrics and probably the best known neonatologist of India. Dr. Ramesh Poddar, professor of pediatrics, Mumbai, at that time was chairman of the Asian Congress of Pediatrics. 10 such pediatricians, including Vinod Paul, who now is the Niti Aayog member. They evaluated our trained community health workers for 3 days. At the end of it, Meherwan Singh, as the chairman of that committee, said that these semi-literate women from Gadchiroli, the Arogya Doot of Search, we call them Arogya Doot of Search, know about newborn care more than the MBBS graduates from the All India Institute of Medical Sciences. It was, of course, very kind of him to have said so. And with that green signal, we gave the power of providing newborn care in the villages to these community health workers. Here the same Kajubai is giving injection antibiotic, gentamicin injection to a newborn baby in her village, baby which had suspected neonatal sepsis. We continued to monitor quality, intensive supervision, coverage of newborn care went on improving as the intervention went ahead. An independent team continued to monitor child mortality rate and newborn mortality rate. Look at the impact, because the impact on the NMR was the main outcome indicator. The yellow line that you see is the NMR in the control area. And though actually trial was only for 3 years, but here I am showing data for next 10 years. The NMR in the control villages, and control villages means where government care, the usual government care continued. NMR has practically remained at or around 60 with some random fluctuation, because these are only 47 villages. It is not a huge population. So essentially NMR remained at 60 for 10 years. And the NMR in the intervention area from 62 to begin with steeply came down. Within 3 years it came down to 26. Field trial was over there, but as ethical responsibility we continued to provide home-based newborn care beyond that. So the intervention, research intervention then continued as service intervention, and it still continues today. Nearly 25 years after it was introduced and nearly 22 years after the research trial was over, as our obligation, ethical obligation, we have continued to provide this intervention in all villages. 70% reduction in NMR. It was unheard of. Let me tell you that, look, Boston is the main center of neonatology. Most of the clinical textbook of neonatology originate from Boston. If a new intervention in the US reduces NMR by 5%, probably it would become headline in the newspapers. And here, the NMR had reduced by nearly 70%. And what was the impact on IMR, infant mortality rate? Same villages, same 39 villages, to begin with, as I said, was 121 in 1988. With the pneumonia intervention, it came down to around 80, And with home-based newborn care intervention, it went down and down and down. It got reduced to the level of 30. From 121 to 30. Gadchiroli still remains the same remote Gadchiroli. Gadchiroli still remains semi-literate, poor, lack of health care. No doctors want to come to Gadchiroli and work there. And still this miracle had happened. The IMR had reduced from 121 to 30, and mere coincidence that when the government of India decided its national health policy, it chose 30 as the goal to reduce national IMR by the year 2012, and these women in Gadchiroli had already reduced it 10 years ahead. So who did this miracle? These are the 4 pillars of this miracle. The woman in red sari, the traditional birth attendant, who at that time who is to conduct delivery, home delivery and provide subsequent care, the grandmother, the mother, and the community health worker, or Arogya Doot as we called her, trained Arogya Doot. These 4 women, they are the 4 pillars of home-based newborn care and reducing IMR to such low level. Now look at them little more carefully. What do you find special about them? Anything? The special about them is that there is nothing special about them. They are as ordinary as any other women in villages, and you can find such women in any village of India or Bangladesh or Nepal or Africa or Bolivia. World over, there are women and women and women who produce children and see their own children dying. But select some of them, give them some knowledge, some information, some training and some tools, and they can do this miracle. It is power in the hands of the people. And what power? It is the same Kajubai, 2 decades later on, so you can see her hair has grayed. But these are the equipments that she works with, and she carries all those equipments on the shoulder bag, 1.5 kilo, but that equipments or shoulder bag on her shoulder, and with knowledge in her head, and skills in her hands, and compassion in her heart, that trained community health worker literally becomes a mobile newborn care ICU. She can turn any home, any hut into sort of newborn care unit with her presence, and by working in collaboration with mother and grandmother in TBA, she provides care to all of them. So this is the logo we designed for this home-based newborn care. That hut was dark, that mother was alone, helpless, entrusted to take care of that baby who was likely to die, but just open that window of knowledge, training, some medicines and equipment, and that woman becomes empowered, and on her empowered hands, she can take care of the baby at her bosom and of the entire family. Essentially, this is power to the people. This is essentially transferring health and medical power from textbooks, from research laboratories, and from hospitals to where the problems are. And not only transferring where the problems are, but transferring solution, but also transferring the power to the solution. So home-based newborn care essentially is an empowerment model. Now, as any researcher would like to do, we published this. It was published in the Lancet. I must share with you one surprising experience that I had. When this manuscript was sent to the Lancet, in those days there were no emails. We used to correspond, you won't believe it now, but used to correspond by post department. And so 3 weeks after that, I received a letter from a pediatrician in South Africa. I would reveal the name. He said, Dr. Bang, I know it is unprofessional or unethical for me to directly communicate with you because Lancet has sent your manuscript to me for review. But I cannot help but congratulate you even before this is published, that this is going to be a revolutionary paper in the field of global neonatology. It got published. Lancet not only published it, but several years later, when Lancet Department of History and editors together published this volume, the vintage papers from the Lancet, they selected what they thought were the milestone papers ever published in 180 years history of Lancet. You have papers from Robert Koch, Louis Pasteur, paper by Ronald Ross, Benting and Best, Alexander Fleming, penicillin, and when you come to 90s, there is this paper on home-based newborn care from a remote place called Gadchiroli. I am cutting short this story because I don't think we have infinite time. But after it was accepted as a scientifically valid evidence that you can reduce newborn mortality and IMR using this approach, we went through series of repeat studies. Studies were first repeated in Maharashtra at 7 places, project called Ankur. Then Indian Council of Medical Research repeated it, replicated it in 5 different states. Everywhere the results were very positive. It was feasible, it was effective. And finally, Planning Commission sent a special team to actually see this approach in Gadchiroli, and the committee highly recommended to the Prime Minister, and home-based newborn care in the 11th 5-year plan and later on even in 12th 5-year plan was selected as the mainstay of strategy of India to reduce infant mortality rate. We developed training strategies, training design modules, etc., trained national state trainers and helped Government of India to develop the national program, ASHA program. 800,000 ASHAs have been trained in home-based newborn care. Except for Kerala and Tamil Nadu, in all other states, home-based newborn care through ASHA has been introduced. And the last year, Health Ministry reported to me that 11 million rural neonates received home-based newborn care. So it became, and you can see in the same diagram, there are red dots. So these are the places outside India. So Bangladesh, Nepal, Pakistan, and in Africa, in 4 countries in Africa, the replication had started when this slide was made. But later on, WHO, UNICEF, Save the Children, all together came out with a joint declaration that where hospital care is not accessible, which is actually most of the villages in developing countries, home visiting and home-based newborn care was the best optimum solution. So this approach, which began out of the need, felt need of the people in Gadchiroli who told us that our children die, can you do something? And through the help of Kajubais and Mayabais and Indirabais and those 4 women that I showed you, they are only representative of course, but this approach from Gadchiroli, it became global. If you look at the WHO report, today 80 countries and country programs of UNICEF and WHO are using this approach globally. And while we thought that we had solved a problem, new problems emerged: high BP, stroke, heart disease, cancer, non-communicable diseases. And our colleague Dr. Yogesh Kalkonde is leading a study, and he is one of the fellows present here, is leading a study on how to control stroke incidence in Gadchiroli. So the story continues, the approach and the story continues. So what do we learn from this? The purpose of this, sharing this story, we all know that knowledge is the new form of wealth. How research is conducted will determine who becomes wealthy. Earlier, land was the main source of wealth. Those who had land were landlords. Later on, capital became the main source. Those who had the capital became the capitalists or industrialists. In the knowledge era, those who will own the knowledge or those who will generate the knowledge, they will be wealthy and the world will be divided into two: knowledge wealthy and knowledge poor. If we do not want this chasm, this gap, to further increase polarization of the world into rich and poor, in the sense knowledge rich and knowledge poor, how do you do that? How should we conduct research? Because the research is a way of producing knowledge. But whom do I make rich? There is another ethical dilemma for a researcher like me and you. A researcher, a typical researcher, gets publications, gets grant, gets career growth. But what about the people? What do they get? The research that we conducted on the people of Gadchiroli, the sickle cell disease, what did people get? Nothing. I am actually ashamed of that piece of research. But I shared that story, how we learned from the mistake. I'm not proud at all of the sickle cell study that we did. And if the researcher is not able to solve the problem, as it happened in the case of sickle cell disease, it brings in frustration. This picture many of you might have seen. This is a very, I don't know whether I should call a famous or infamous picture. At the peak of the famine in Ethiopia, either Time or Newsweek magazine's photographer took this photograph. That hungry, starved, malnourished child is waiting to die, but next to that child is vulture is also waiting for the child to die. This photograph was acknowledged, applauded world over because it hits you. That photographer received the global, international award, but within 6 months he committed suicide. He said, I got award, but I could not save that child. I left that child to die there. And so researcher, if he conducts research, but if he cannot really see the benefits reaching to the people whose problem that is, it brings frustration. So that is our ethical dilemma. How can we conduct research where not only we but the people also benefit, and we can get the joy of people benefiting from my research? Otherwise the researcher gets alienated from his research. Yes, publications are published. Yes, in such conferences I make presentations. But if the problem remains like that, how can we connect in taking the solution to the people whose problem that is? So the questions that we have, a typical research that we have, and one solution, one answer that we have found, not necessarily the only answer, but then usual question is, where should I do my research? I am a young researcher, I want to start my career, where should I do my research? About 7-8 years after we settled in Gadchiroli, my professor of epidemiology at Hopkins, Dr. Leon Gordis, had come. Leon Gordis, probably the best teacher of epidemiology I have ever met, and I was taught by. He was at that time chairman of the International Epidemiology Association, so very, very senior epidemiologist. So he had come to India. So I went to meet him and I was describing to him what were we doing in Gadchiroli. So Dr. Gordis looked at me for a few seconds and then he said, Abhay, I am envious of you. So I thought, well, you say it out of courtesy, but there were tears in his eyes. And he had large glasses. And his eyes looked very huge from those glasses and they were full of tears. So I was little embarrassed. I said, what happened, Dr. Gordis? He said, Abhay, for 40 years of my life, He was a pediatric epidemiologist. So he said, I did research only on Gaucher's disease. I am a global expert on Gaucher's disease, but I am not sure that I saved even 8 children throughout my life. Whom did my research benefit? And here you are a lucky couple, he said. Here you are a lucky couple. You have found a place where you throw a stone and you find a new research problem. Yes, that was the beauty of Gadchiroli. And so from that experience I would say, go where the problems are and not where the facilities are. Because the places with facilities have no problem to solve. There you are a problem. But then we are all keen that there should be facilities, and so our main criteria of selecting a place to work is where the facilities are. But there are so many applicants there, so naturally you become a problem. So I would say, though my experience base is very narrow, and yet based on that I would venture to say, go where the problems are. Then the second question, how should I identify my research problem? All of us, including me, we usually look at the literature search and look at the research journals and where are the gaps so I can write some research proposal. But Gadchiroli experience tells us little different. It says, listen to the people. When people gave us that problem, white discharge amongst women, our first study protocol that we wrote on study of gynecological problem in rural women, essentially to study the problem of white discharge. For its review, when we presented at Johns Hopkins, the experts in Baltimore said, are you fool? Why do you want to conduct research on white discharge amongst women? Indian Council of Medical Research gave us grant, but Professor Ramlinga Swamy established a committee to review our proposal. They said, are you a fool couple? You have gone all the way to Gadchiroli, do some exotic research on cervical cancer or hepatitis B. What are you doing? White vaginal discharge. But this is what women wanted. And I have not shared you that story, but that one piece of research in 2 villages, which showed that 92% women were suffering from gynecological problem, 50% of rural women had white vaginal discharge, and that was their main anxiety. For them, nothing else existed. White discharge amongst women and alcoholism amongst men. These were women's 2 major priorities. So listen to the people and they'll give you lifetime list of problem to solve. As I said, we have not still done with the 4 problems that they gave us. Observe and data. These are the basis on which you select, you identify the problem, and the third question, how should I conduct research? Now, we already discussed the limitations and the ethical dilemma of current research approach. So, can there be a research approach by which people also are enriched? People are empowered? I would like to classify the research studies in 4 stages. One is research on the people, our own study of sickle cell disease. Research on the people, where people, though little exaggeration, but I would say people are almost study subjects or guinea pigs. Research on the people. You do a vaccine trial and leave people where they are. Research on the people. Second is research for the people. No, I am not showing it there. Research for the people, better. But research is done for the people, but people have no role. Still, research benefits them. But I would like to propose the third stage, research with the people. I'll come to this research with the people. What does it mean? What are the criteria? But there is a 4th dream stage for me. I know it's not a current reality, but research by the people. Will it be possible for us to move from research on the people to research for the people to research with the people, and finally research by the people? Research with the people will be characterized by that people should need it. People should understand it. People should participate in doing it. And finally, people should use it, and then actually finally people should own it. And the research approach should not only share with the people at every stage, from identification of the problems to the delivery of the intervention or solution, to the sharing of the knowledge and and finally it should leave people more empowered so that they can now continue to apply that solution to their own problem. So research with the people is the approach we learn from this laboratory of Gadchiroli. Finally, will it produce the impact? Fine, might be a good sociological dream, but then will it produce impact? Several years ago, about 2000 years ago, Archimedes, wherever he was, in Greece probably, so he said to his emperor, he said to him that give me a lever long enough and place to stand outside the earth, I promise you to move the earth. Now, of course, everybody laughed at that time. What is this old man saying? How can with his weak and shriveled arms, can he really move the earth? But now we know from the principle of lever that yes, it is possible. If the lever is long enough and if he has place to stand outside the earth, yes, old man like Archimedes could have moved the earth. I would say that similar such lever is research with the people. Standing outside the establishments, but standing with the people. And with the power of this lever called knowledge, even these women from Gadchiroli could produce something which moved not only national policy but even global policies. Research knowledge is a very, very long lever. You don't have to go anywhere, but sitting in Gadchiroli, this piece of research has targeted New Delhi and Geneva and New York and Washington and global policies. That is the power of knowledge which is generated when we attempt research with the people. I would like to end that the research in Gadchiroli continues with the new and newer problems. But then the whole story that I shared with you, in hindsight, I feel I shouldn't have even talked. Reason being that 4000 years ago, Lao Tse in China had already said it. When in his very well-known poem he says, go to the people. Go to the people, live amongst them. Listen to them. Learn from them. Begin with what they know and build upon what they have. And the problem is solved. That is what research with the people is. Thank you very much. Thank you. Thank you. Thank you. Thank you.
Thank you, Dr. Bang. A truly humbling experience. Questions? Dr. Bang wanted a fairly long question-answer session and an interaction. So please don't feel inhibited.
I was wondering, how do you decide to continue with these control villages where you don't have the infant mortality intervention that's going on? Yeah, are there dilemmas that you face?
Can you repeat your question?
The data you showed for the child mortality, which dropped because of your intervention, but you have these control villages which still continue, it seems, without intervention. What kind of dilemma do you face with this, letting those villages continue, and how do you deal with it?
Look, initially when we began, we didn't know what we were going to do. And the control area were served by the regular government program. At the end of this trial, we had this issue, what do we do? Now, we didn't have funds to introduce this in the control area, but at least we couldn't withdraw it from the intervention area where it had proven so successful. So, we thought that why only 39 or 47 control villages? The whole of India is our control area. And this should be available not only in those 47 control villages, but in 5 lakh villages in India. And that's why we very systematically worked on replication and then getting into policy and help Government of India to develop ASHA program and home-based newborn care in ASHA program. And today, even in the control area, it's no longer a control area, it's actually government-served area where home-based newborn care is delivered by government ASHAs. So, the so-called initial control area does receive home-based newborn care, but through government services.
Excuse me.
But what you asked or had become at one point of time very burning ethical question. A book published in the US by I think Macmillan or Oxford University on ethics in research, health research. One of the case study was on home-based newborn care, and without ever contacting me or communicating with me, experts on medical ethics from different parts of the world, especially from the US, wrote a scathing criticism of unethical Dr. Abhay Bang. And the ex-editor of New England Journal of Medicine wrote that Dr. Bang had been watching neonates die without providing them intervention. Now, they never really studied what we were doing in Gadchiroli. The infant mortality rate and neonatal mortality rate in both areas, they are measured in hindsight, retrospectively. We don't look at the newborn and observe sick neonates in control area and let them die and see what the neonates, what is the NMR. So, the control area is not observation of neonates while they are alive. At the end of the year, we do survey, house-to-house survey to collect information, how many babies were born and how many died in the whole year. So, there was the ex-editor, who was he? Probably Angela Marcel. She argued that it is completely unethical to provide anything less than the best global standard of newborn care, which means actually that you should provide to every neonate in the world the neonatal care of the Boston standard. Now, the issue of appropriateness, it comes there. Can you really provide the same standard? Is it necessary also? And if you are not able to provide the American standard of newborn care, is it unethical to provide anything less than that? So, choice is not between 0 and the ideal, but then appropriate, something which is appropriate to the population that you are working with, and where not only the solution is provided, but even the power to the solution is also provided. We thought that it was completely ethical, but this question has been asked earlier also. Look, our work with malaria has been a story of ups and downs. Gadchiroli population is 1% of the Maharashtra's total population, but it contributes more than 50% of malaria in Maharashtra. So very concentrated malaria, that too falciparum malaria, and that too chloroquine resistant falciparum malaria. So deaths also continue to occur. I don't think we have made any major breakthrough. We have attempted several standard really measures, insecticide spraying, but resistance developed, and then using impregnated bed nets, partly effective, and training community health worker for the taking blood smear and treatment. Every 3-4 years we see our malaria incidence declining. We feel very happy. We start patting ourselves, and 4th year malaria fools us. There is again a huge epidemic, and we find that we are back to the square one. So we are still struggling with malaria. I don't think, and actually this is not issue of only Gadchiroli, but this is issue of whole of India. There are 100 million tribal people in India. They constitute 9.4% of national population, but they carry 60% of the burden of falciparum malaria in India. So very improportionate burden of malaria is borne by tribal people, and yet I don't think we have very effective solution so far.
Thank you very much for this inspiring talk, very different from what at least I'm used to here. My question regards, you show results until 2001 on these deaths, of child deaths going low. But you keep using the same measures, and these days you show the same pictures. So it's really still going lower and lower. So empowering people gets improving your thing, or really gets the level of 30, and you cannot go, below that. How can?
Very good question. Very good question. I think that this method has its limitations, and not that it can bring down NMR or IMR to the level of 10. It can reduce IMR maybe somewhere between 25 to 30. And wherever it was replicated in Maharashtra, in India, usually that was the lower limit reached. Beyond that, you need more technological solution, because then the most important cause of death below that remains the extreme prematurity. And for extreme prematurity, then you need higher level of technology. So yes, this method has its own limitation. Maybe it can reduce NMR at best to the level of 20 and IMR to the level of 25, but not below that.
Great talk. So I want to know about this financial aspect of this. Means the women you recruited for neonatal care and everything, from where the money came to support them? Were they volunteer or something? From where the finance came?
Yeah. This was conducted as a study. Whenever we find that there is a priority health problem to be solved, we convert that into a research study, so that it generates sound, robust scientific evidence also, so that if at all we succeed, then the intervention can be made available elsewhere also. So this was turned into a research proposal, and MacArthur Foundation in the US had supported this study. And women were paid. They were not entirely voluntary. They were paid not very highly, but little better than the wages that they received in the villages. We also conducted the time motion study, and then average work that a woman in 1,000 population needed to do was 1.5 hours per day. So these women were paid. Part of that payment was fixed payment, and part of the payment was really work-based payment, including the quality indicators. And same method has been now used in the ASHA program also, for providing financial incentives to ASHA.
Hi. So I was just curious about one of the slides where you have the whole of India map, and then almost whole of India was using your model except for Tamil Nadu and Kerala, which essentially the map looked like 2019 election result. But then you don't have to worry about why is it so? Is it because, you know, Tamil Nadu and Kerala had more healthcare units and then IMR was already lower, or?
Yes, precisely. That is the explanation. Because their IMR was lower than 25 at that time. So they didn't need home-based newborn care.
No, but then why they are not following that model also? Why whole of India is not following that model in terms of, you know, having more healthcare units, or the government is not doing enough to have more healthcare units, and then following your procedure as well as having more healthcare units, can you still reduce IMR?
Look, the Kerala and Tamil Nadu don't have only healthcare units. They have several other social variables which are different. Kerala's female literacy, Kerala's women empowerment, Kerala's political awareness, and Kerala has been studied umpteen time as the model of development.
Okay.
And so, I am sure Government of India would like to replicate the whole of Kerala all over India so that the IMR comes down to 10.
Okay.
But it's not so easy. And so, because Kerala and Tamil Nadu, by whatever approach, the social developmental approach, they had already solved the problem.
Okay.
They didn't have problem of NMR to be solved to the level of 25 because their NMR was already lower than that.
Okay.
So the state government said that we don't need.
It's not necessary.
And I would support their really decision that they didn't need
Okay.
home-based newborn care.
Okay.
Institutional delivery already was very high in Kerala and Tamil Nadu at that time.
So, very fascinating and inspiring talk. I'm stuck with the research with the people. So, my could be a controversial question. Urban population is having more diseases and more pathetic condition these days than I will say than rural in terms of number of diseases increasing because of pollution and other things and lifestyle and stress. And so point is that is also research with the people if we are staying within the urban population and doing something for them. What do you take on that?
I don't think I have understood your question. The diseases pattern is changing and the diseases are increasing. That's true. But I mean, what is your question exactly?
My question
about
is,
the research with the people?
I'm inspired, highly inspired. So should I go to, I'm doing on research something more relative to the lifestyle, for example, stress, inflammation, which is more relevant to, I think, to the urban population. So it is also kind of staying in the city and doing the research for the urban population. So it's research with the people and not going to the rural population.
Look, research with the people doesn't distinguish between urban and rural people. There are people and people everywhere.
So I'm correct in that way. If I'm doing my research in the city, I'm fine.
You are correct.
That's what I want to say. I want to justify myself if I'm
You are correct on that aspect, but the research with the people is not only going to the people, but there are several other things that the people should understand it, they should need it, they should participate in solving, and ultimately they should be left with the power to solve the problem. And by the way, just to correct you, that the diseases that you mentioned, the non-communicable diseases, are not only limited to urban. Yogesh is sitting right next to you, and Yogesh is working on reducing stroke by managing hypertension and diabetes in rural Gadchiroli. So places like Gadchiroli now have problems of non-communicable diseases. So they are ubiquitous.
Excellent. Thank you. Purnima Menon from IFPRI. So I was wondering if one is to do the inquiry of what are the challenges that face people today in a situation where we have sort of this government scale up of many of these initiatives, a lot of the challenges that some of us one sees is a lack of delivery of these existing programs, and that sort of opens a space of research that is quite a bit more around implementation research, and it relates in a sense to how the people who are tasked with delivering government services have themselves been treated, motivated, incentivized or not. And so I was wondering if you could speak a little bit about whether and the extent to which your own research community at Search is also now working on some of those particular issues that relate to the scaling up and the implementation research, and the research on actually how we can support the delivery systems and the people within the delivery systems to help achieve some of these goals. Because I just see a situation where you have 15 bureaucrats or health specialists deciding what a single ASHA worker can do, and I'm going, this is an inverted pyramid. This is not how human resource structures are supposed to work if you want effective and supportive service delivery. We've seen the same with self-help group programs where 15 people want the same community mobilizer to work with women's groups, and there's a part of me that just is boggled that we can even expect that these women can now do it all. So I would love your commentary on that. Thank you.
Your question is very difficult because on that point, I don't think I have been able to solve that. We have worked with governments and national policy shaping and implementation, etc. But moment you give power to the hands of the bureaucrats and power in the hands of health hierarchy, somehow, unfortunately, the whole approach and relationship is such that it disempowers people. What else could be done? Of course, one could work with the system and try to make some corrections. There is no hopeless situation anytime. There is always scope for some improvement. One could work with ASHA, more transferring more power to them, etc. But in the whole setup, actually, ASHA has been so disempowered. And she has been converted into a sort of a tool in the hands of, as you very rightly said, bureaucrats sit in Delhi and without understanding anything just decide that she should be working on non-communicable disease or she should be working on sexual abuse against women. But anyway, so what else could be done? So I don't have a very complete answer to your question. But I'll take another example. Alcohol was one of the problems which people told us, and we started working on it. Initially, we collected with the people data in one village called Bodli. How big is the problem of alcohol? The data was collected in Gram Sabha. How much money do you spend on alcohol? Who sells alcohol to you? How much money is he making? Within 1 hour of participatory discussion, people found that they were drinking alcohol worth 10 lakh rupees per year. And this is year 1988 I am talking. So suddenly, frightening number came out. We held similar such discussions in number of villages, and look the power of discussion. It might appear very benign to us, but when you discuss with the people their own problem and try to untangle what could be the cause, what could be the magnitude of this, and gradually what came out that government policy didn't allow actually alcohol to be sold in the tribal areas, but there were 62 alcohol shops licensed by government of Maharashtra in Gadchiroli district. And they were selling alcohol worth 20 crore of rupees per year, while the whole development plan of the Gadchiroli district was 14 crore rupees. Now, with these two figures, that the total amount of alcohol sold in Gadchiroli district was 20 crore rupees and development plan of government was 14 crore rupees, we went from villages to villages. Now, women already had their own experience of suffering because of alcohol. So they had all the emotional petrol, fuel there. We just put this trigger and a huge public movement developed against alcohol in Gadchiroli. And you won't believe, but within 6 years, government of Maharashtra had to introduce prohibition in the entire district. Now, you may or may not agree with the prohibition as the solution. I am keeping that aside. But by investigating their own problem with them, quantifying it, identifying what were the policy reasons for it, people stood up against the government policy. Gadchuli was known for Naxalite movement, but this was completely democratic, peaceful movement against alcohol, which continued for 6 years, and finally government relented and introduced prohibition in Gadchuli. We were very happy. But then implementation was very tardy. And so for past few years we are working with government of Maharashtra on one side and with the communities on other side, how to implement the prohibition and tobacco control together. Alcohol and tobacco reduction at the district level in a project called Muktipath in collaboration with Maharashtra government. Tough, very tough to work with government. I don't want to list the problems here, but in this Muktipath approach, we are working with 1500 villages. Out of these 1500 villages, 1200 villages have constituted village level committees to reduce tobacco and alcohol. 600 villages have introduced community ban against alcohol. On tobacco front, we are not so successful so far, but 200 villages have introduced tobacco ban on the village, on the tobacco sale. And so by involving government on one side and on communities on other side, alcohol and tobacco is reduced in Gadchuli. Every year we are conducting annual district sample survey. Our last sample survey shows that alcohol and tobacco has been reduced more or less by 25%. Not a great victory like IMR, but this is tougher problem. But I mentioned it that there are ways of working on other problems also, where sometimes you have to fight against the government, but then later on handshake with the same government and in a collaborative way try to implement. But then if it is only government solution, prohibition, it is only partly successful. But involve communities into that, and today 1200 villages are trying to reduce alcohol and tobacco in their village. So there are partial solutions. I wouldn't say there are complete solution. The home-based newborn care was conducted in a relatively smaller laboratory, maybe 80 villages, but still smaller laboratory. When your scale becomes larger and larger, it becomes more and more difficult.
Here, Doctor. So this is great talk. I have a dilemma that I wanted to clarify with you. So you have all partially answered my question. So my point was, you were working with the people and who were essentially not very well educated or minimum education in that region, and you solved the problem. But I give you two examples. One is polio vaccine and another one is misuse of antibiotics. That is so prevalent in not only in rural areas but also in the urban areas where education level is essentially not that low. How do you think this model would work in these situations also? And the other question is, could you stop cow dung plastering in those villages?
Pardon, what is the last question?
Cow dung plastering.
Look, in case of polio, for example, the vaccine research, I think that vaccine research has to go in a little different way, and probably people's involvement there would be minimum. But once the vaccine is available, then comes the issue of operational research or applying that in the global program. There, of course, without people you can't implement it. Because who receives the vaccine? We look at it as the polio eradication program either by government or by global agencies. We look at people as they have to only open their mouth and 2 drops of polio. We reduce them to swallowing 2 drops. But actually they are participating. They are not only cooperating, they are cooperating, but if that cooperation is with knowledge, if that cooperation is to mobilize the other people, children in the villages for receive vaccine, then that cooperation can turn into participation, into active participation. So on one side, they will have partnership with the government program to reduce polio, but on the other side, there will be enlightened people in the village who would understand the polio and the vaccine and the importance of this kind of mass programs. And then same power can be applied to several other problems. So even for the large scale program, I would say, our often approach in the vertical programs becomes like this: show me your arm and I will pick you a vaccine. But then involving communities with knowledge and understanding and participation increases power manifold. Especially that would become very important in non-communicable diseases where there are issues of lifestyle change. Now, can you change somebody's lifestyle without his or her own participation? So, actually for non-communicable disease, we have to have a program or approach where people participate. And if they participate with knowledge and understanding, then probably the solution to contain non-communicable disease will be more lasting. Giving only one tablet is definitely a solution, but give a tablet with their understanding. In hypertension and diabetes detection, can we involve communities? In alcohol and tobacco control, can we involve communities? Yes, there is a very much scope. So, I think in every health intervention, there is a scope for involving communities, working with them, so that finally the solution can be transferred to them. If not entirely, at least partly. Vaccine production might still continue with naturally in laboratories and factories. But the vaccine application, distribution, vaccine acceptance is very much a domain where people can participate. And in the beginning itself I said that this is not the only solution, this is not the only approach, there would be context specific and the problem specific approaches. But to overcome that ethical dilemma of a researcher, we need to bring in as much as possible people's role so that the knowledge is transferred finally to them. At the end of the research, if they are left at the same position where they were to begin with, I would say research has not been completely successful.
So, thank you for the thought-provoking talk. So, I'm curious about, you alluded about the health problems, what was prioritized. Can you share us what sort of societal, technological, economical problems they have prioritized?
Can you specify your question a little more, sir?
So you talked about the health priority, what people have listed. Are there any other technological or societal problems which is actually burdening more?
What would you consider the alcohol?
Yes, yeah, you alluded one of that. Yes.
People of course have several other problems. The most important problem for the people there was and is their ownership over the forest. Because forest is the main source of livelihood. In those issues, we have not taken the lead. But other people who have tried to work in Gadchiroli, I would say, we have partly supported them. Because we have our own limitations of domain expertise, domain competence. So there are several other issues, the economic issues, the educational issues, the roads and electricity and corruption and police atrocity and Naxalite problem. What can you do? So we have not, I don't think we can claim that we have tried to work on every problem. Naturally, people come up with those all issues, we console them, we show them sympathy, and then we suggest to them that where else could they go, where probably they could find the solution rather than us. So we are not the only source of solution. So the social, economic and several other issues, we have not worked to that extent as we have worked primarily. Our focus is on health and health problems.
Soumitra Pathare, I'm a mental health researcher, public mental health, and we've tried to, in our research, actually tried to apply some of the principles that you've talked about and we've read about. What I think I want to make a point and wonder if you'll agree with me is that I think participatory research is not just about participation, it is the transfer of power. I think it's ultimately the notion of experts and recipients, and what you're trying to do is to flatten the power structure. So in mental health, for example, we also have people who have lived experience of mental illness now being referred to as experts by experience. So, you know, they are as much of an expert as I would be an expert because I've gone to medical school. And there is also a good movement and a lot of research which is being led by service users. These are people who have lived experience of mental illness, long-term mental illness, who actually decide and do the service, who do the research. And so maybe the point that really needs to, because I didn't hear it in your wonderful talk really is the whole notion of power. And this is actually the whole issue here, is the power dynamic that is being shifted that you're talking about.
Well, thank you for saying it more explicitly than I said. If I didn't say it as much in as many words, then you complimented it. Thank you. I completely agree with you.
Dr. Bang, thank you so much. I really don't have a question, but I think I wanted to just share that each time I listen to you, you make me introspect. You show a mirror that we as researchers often conveniently ignore looking into. But I think beyond the work that you and your team has done in Gadchiroli, you have also touched lives and inspired several young researchers in public health, including myself. And one more thing I think which personally I benefited is that what you shared about ethical controversy that happened around a home-based trial later on. And some of us actually wrote a commentary in Indian Journal of Medical Ethics actually supporting your point of view. I really feel that unfortunately ethics has come down to a checklist kind of an approach with committees, And I truly sort of learned from that episode how ethics need to be a constantly reflective process on side of researchers, considering the norms set by the people with whom this research is being done. So thank you very much.
Thank you.
If there are no more questions, I would like to thank Dr. Bang once again. Thank you so much for an inspirational talk.
Thank you.